us today. Good morning, folks. We're still letting folks in from the waiting room. My name is Sharon Merriman Nye. I'm with the Center for Drug and Health Studies at the University of Delaware, and I work on the State Epidemiological Outcomes Work Group, which is the SEOW to most of you. Some of you are familiar. We've seen you here before. You are active participants, and we have a lot of new folks joining us today for this, the second of our annual meetings. Semi-annual meetings, excuse me. We're really happy to have you all here. We know how busy everyone's schedule is, but I would ask if you wouldn't mind introducing yourself in the chat. Let us know where you're from. And if you want to say anything about how you use behavioral health data, that would be great, because as you know, and we'll get into this in a minute, what we do here is really promote the use of data to support behavioral health interventions, prevention, programming, recovery, the whole spectrum of work in this area throughout the state. So while we're waiting and signing in, I'm just going to briefly introduce the team members. MJ Scales, who most of you know, I think, is here. She leads this project. Shauna Leahy is here, and Emily Rell. They're program specialists, and they do a great deal of work with the data, finding the data, producing data documents, and so on and so forth. And as I said, my name is Sharon Merriman Nye. So MJ, do you think you want to go ahead and get started with the slides at this point?
Yes, ma'am. Thank you, Sharon. Good morning, folks. All right, as Sharon mentioned, if you're new or joining for the first time and you'd like to be connected to the SEOW network, I will put my email address in the chat. Please let us know. And if you are not already receiving the SEOW newsletter, if you're already not a part of the announcements and the listservs, please email me directly and let me know, and we'll make sure you get added. All right, the SEOW is supported by our partners at the Delaware Department for Health and Social Services, Division of Substance Abuse and Mental Health, through funding from the Substance Abuse and Mental Health Services Administration, or SAMHSA. Today we will do a brief overview of the SEOW. For those folks who are not familiar with the SEOW, we'll discuss our goals, new data products. We will have an introduction of data on treatment and recovery. I'm very excited on this topic. As you all know, this month is Recovery Awareness Month. It's been really robust with activities here in the state, but also across the nation. It's also Suicide Prevention Month, and obviously those things, efforts and energies go hand in hand for both of those awareness months and activities. So we're excited to talk about a little bit of data, and then our key presenters from Lyman Recovery and Wellness, Michael Webster and Olivia Tennant. And then, of course, as we always do, any information that you all have, flyers, news from the fields, events, so on, please share those with us so we can make sure that folks can attend and come out and support.
All right, so a bit about the SEOW goals. Our first goal is to build monitoring and surveillance systems to identify, analyze, and profile data from state and local sources. We also identify, share, and analyze data and create data-guided products that inform prevention, treatment, and recovery planning and policies, as well as train agencies and communities in understanding, using, and presenting data effectively. And some newer things since we last saw you in February, we do have, as MJ noted, the SEOW newsletter that we've sent out a few times at this point. And as MJ said, email her if you are not part of that listserv and you want to be in on that. They get sent out every 3 weeks, just kind of some information, highlights from the field, data products, webinars, that kind of stuff. We also always continue to either create or update new infographics with data. We have updated a lot of our older infographics, as you can see in the list here. And we continue to do those as we see fit and as new data comes out.
Yeah, I want to tag in here that our annual Epi report is in progress. We're really excited about that. It'll be posted on our website, but we'll also announce when it's done. It comes with its own set of infographics. It's a very robust report about behavioral health data for the first state, and also some national comparisons and so forth. So we're really, very excited about that, and that should be out next month or so. As you're putting information in the chat, please know that the team is monitoring it. We'll respond to questions, and we'll follow up with you on any requests. So if you have data requests or want to learn more about any particular thing here at the center or the SEOW in particular, we will definitely take note of that and follow up with you via email, or if we have time today, we can dig into it. Otherwise, we'll certainly follow up with you. All right, so because we're talking about recovery today, we wanted to share with you that SAMHSA is seeking public comment for new data collection, especially their core outcomes of recovery. So it's 13 recovery-oriented measurements that align with SAMHSA's approach to recovery. They are adding to the tool and they're seeking public comment. We'll put that link in the chat for you. And if you're interested, please, we encourage you to provide your feedback on this. Sometimes if you're in this work, you know that certain measurements can be challenging because they don't quite fit the reality of what we experience when we're serving others. And so I strongly encourage you to provide feedback on that scale so that we can capture in a more accurate way what's happening with folks who are living in recovery, who are seeking recovery, who love folks that are in recovery. So please take an opportunity to do that if you can. All right, so we are talking about treatment and recovery today, but we do want to acknowledge that treatment and recovery are highly personal, and successful interventions vary based on the needs of the individuals. For that reason, the data that we're going to talk about today, it doesn't distinguish between is a person in a clinical service, are they an inpatient or outpatient? Are we talking about peer recovery supports? Are they attending AA, NA, or taking any sort of psychotherapeutics for things like depression, schizophrenia, and so forth? For the purpose of this presentation, in the beginning, we were using SAMHSA's working definition of recovery from mental health and substance use disorders. This is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Here on the right-hand side are the 10 guiding principles that SAMHSA, through a work group several years ago, came up with. That work group included folks who were in recovery. And so you'll see these kind of pop up in different places, NAMI, other recovery interventions as well. So hope, self-determination, and self-direction. There are many pathways to recovery. Recovery supports and understands the holistic person. It's supported by peers and allies. There are social networks for recovery. It is culturally responsive. It is trauma responsive. Reflects individual, family, and community strengths and responsibilities, and at its core, respects the individual. And if you have other thoughts you think should be added on there, feel free to throw them in the chat about, you know, elements that you think are critical to successful recovery. All right, so when we talk about treatment, we're using NSDA here. If you're not familiar with NSDA, the National Survey on Drug Use and Health is a national survey conducted by SAMHSA or administered by SAMHSA. That data is collected throughout the country and the District of Columbia. So we use some data here. It's a couple years old just because of the combination of years for Delaware. So this is adult level data. Respondents who identified as needing substance use treatment in the past year, about 21%, and respondents who reported receiving substance use treatment in the past year, about 4%. Regardless of what data source you use, we know that not enough people receive treatment for substance use disorders, whether that's due to logistical barriers, such as those living in rural settings, whether that has to do with not having access to culturally responsive care, or other barriers such as, you know, insurance or cost or things like that. And so we know that this is an issue, especially, and that includes folks who are receiving mental health treatment. There's a shortfall in what people need and what they receive. That could also be a lack of education. There could be stigma. There could be all sorts of issues that contribute to this, but this is just the national estimates for the state of Delaware, or NSDA estimates rather, for the state of Delaware. This is recovery data from NSDA. This is the national data. I think what's important here is that this is a perceived problem and perceived recovery, right? So this is not an outside measurement of recovery. This is a person responding to the national survey, perceiving that they are in recovery, or that they are at a position that they are operating in recovery from either a substance use challenge or a mental health issue. So you can see that about 11.8%, so 12% of folks reported ever having a substance use challenge. This is, again, a national number. And about 71% of those folks believe or report that they are in recovery. Mental health, about 1 in 4 folks ever had a mental health issue or challenge, and about 66% of those folks reported that they are operating in or living in recovery from those mental health challenges. When we look across groups, and this is a report that, again, that SAMHSA put out, their recovery from substance use and mental health problems among adults in the United States, highest reported recovery from mental health challenges or disorders is the word that they use, were folks who were insured. And I think that's an important, you know, social driver of health. We know that whether it's physical health, or emotional health, mental health, that insurance is important to folks' journey through treatment, in recovery, on their way to wellness and healing, regardless of what condition, disorder, challenge we're discussing, right? So they had better overall health. So folks who are in better physical health, more likely to report better mental health recovery, or more often report mental health recovery. We're heterosexual. For me, that, you know, highlights some challenges within the treatment systems, the continuum of care for folks who are LGBTQ, or, you know, any historically marginalized groups. They were never arrested or booked for breaking the law. I do want to say that that is SAMHSA's language, not necessarily MJ's language or SEOW's language, but that language there. So folks who do not have prior criminal justice involvement were more likely to report having mental health recovery for those who had mental health challenges. It was lower among individuals who had past year serious psychological distress and a past year substance use disorder. So that's why we are talking about these topics kind of in tandem, right? Because we know that folks have co-occurring mental health and substance use challenges, but we also know that at times it's a chicken and egg situation, right? So am I in distress because of this reason? Am I using because of this reason? So we often report this data together so that we can understand the fuller picture of what folks are experiencing. So I want to pause here to see if there are any questions, check the chat before we get into our speakers. Ladies, my team, any questions from the chats?
I don't see anything in the chat so far.
I see you, Dr. Davis. We could definitely get into talking about the school survey, maybe not today, but if you want to drop your email in the chat, we can connect you with the right folks and we can have a conversation about that. And one of the team will drop the link for the school survey site, our microsite on our website. All right. Mr. Webster and Ms. Tennant, are y'all ready? I can't see.
Always.
Is it always? All right. So I want to introduce our speakers. I'm so very excited to have them with us today. Michael Webster is the Chief Advancement Officer at Lyman Recovery and Wellness. He joined there in November 2022. His recovery journey brought him to Lyman with over 17 years of nonprofit experience in institutional effectiveness, advancement, and engagement. He earned his bachelor's in strategic and organizational leadership at the University of Scranton and a master's in strategic and organizational leadership at Newman University. His experience spans operational program management, alumni services, and direct fundraising at Newman University and Salesianum. Today, he lives with his wife and 4 kids in North Wilmington, accompanied by his 2 cats and a dog named Ruby. He is joined today by Olivia, and she has been a data specialist at Lyman for over 2 years. She's a contributing key member of the development team. Her role focuses on data analysis and reporting to support performance tracking and process improvement. She is currently pursuing a master's degree in applied statistics at UD, which is exciting to build on her experience with data and statistical methods. So you should have, I'm so excited. Please join me in welcoming Mr. Webster and Ms. Tennant. I'm looking forward to this presentation. Thank you so much. You can share your screen if you like.
You're gonna see us kind of make the work. Olivia, I'll share it from my screen if that's okay. And I'm gonna relearn how to do this in real time. Hey, everybody.
Do you see the share down at the bottom?
Yep, here we
Okay.
go. I think we're all set.
Excellent.
And-
We can see it.
And then I'm gonna, from the beginning. So MJ, thank you for the warm welcome, and it's really awesome to be here. I'm really excited about that. And as you were kind of rolling through the update and talking about legal involved, my first thought was there's so much privilege in how people get treatment, and understanding that intuitively is one thing, but having numbers to provide for that, even the language that SAMHSA is still using versus what is being presented here. So I'm excited to kind of roll through this, and I wanted to give a few minutes to Olivia to maybe say a couple words and introduce herself.
Right, I wanted to thank you again for this opportunity. As mentioned, my name is Olivia. I'm also a student at University of Delaware doing a master's program in applied statistics. I've been with Lyman for a while. It's been really great to connect what I've been learning to real life applications by working here, collecting data, getting interviews, engaging with our clients and whatnot, but then also putting out a graph and saying what we're doing is, it's real because we have quantitative numbers to, measure it. So thank you again for this opportunity.
Awesome. All right, so let's get into it. Today we want to kind of give you an overview of what Lyman is, our mission, and just kind of a brief synopsis of our services. We also want to work through the concept design of how we started to develop a culture around data at a small community behavioral health organization, and then talk a little bit about workflow. And it's progress, not perfection. And where the growth is, what we've been able to accomplish, and then finally kind of give you a snapshot, largely in gratitude to Olivia's work and analysis, and how that has impacted three major areas of the organization. So really quick, Lyman House was started in 1969. Since then, it was started by 8 fearless women, and it was born out of St. Andrews. And for a long time, we were only 2 houses in Wilmington. We were like the OG of sober living. I think the old nomenclature would have been a halfway house. And a lot of people ask, where does Lyman come from? Lyman is based off of a Latin term, liminal. So a liminal space or a liminal incision if a doctor or surgeon makes. And really that's how we envision our mission, is that it's a threshold that people can walk through. And in our history, we started with a men's house in 1969. By 1976, we were able to add a women's house. Since then, we've been able to grow in a measured way. And what that looks like for us is we've been able to add an additional 2 houses. So as of 2019, we had 4 sober living houses, 2 at both gender specific, so men and women, and both were classified as NAR level 3. And then we have transition houses classified at NAR level 2. And around 2019, 2020, we were able to merge with another Wilmington mainstay of community mental health, Triad. Triad gave us the opportunity to add outpatient services. And in full disclosure, Lyman at the time was also engaging with Triad to support their sober living program. So match made in heaven. The good news is it was like almost 4 blocks to 6 blocks away from most of our locations. And that has created an opportunity for us to really envision a continuum of care and to meet people wherever they're at and to provide multiple pathways to recovery. And in 2023, we purchased the Aloysius Butler and Clark building on North Washington Street. What's happening here is that we're adding a 3.1 ASAM residential program. We have an active IOP and we have an outpatient program. We also, for the past 12 months, have been able to sponsor or co-sponsor various events. And some of that started with our alumni, but also adjacent areas. So the things around a person besides recovery as well. So I'm gonna go to the next slide. And then I'm gonna kick it to Olivia, because Olivia, this is an Olivia slide.
So before I get into this, I want to acknowledge my professor. His name is Dr. Stout of the University of Delaware. A few years ago, he recently moved, but he worked as a sociological researcher in the sociology department at the University of Delaware. He was responsible for establishing our data collection methods, as well as connecting Lyman's model to a sociological framework. So the basis of his research asked like one overarching question, like what makes Lyman so special? And we were able to break that down into 3 different parts. The first being our alumni presence. So we have like walking examples of Lyman's success being mutually beneficial in maintaining alumni sobriety and motivating those in treatment. So in our level 3 house, you'll notice just people like walking in and out. Those are people who were in the program and they're there to, help our other clients out, show them the ropes, maybe ask them a few questions, how they're doing, just to build community and whatnot. So this as one of our concepts, it builds community and it maintains alumni sobriety, which will serve as a motivator for those in treatment. This is also an established evidence-based practice, as it's supported by several studies published by the National Library of Medicine and the Journal of Drug and Alcohol Dependency. Am I keeping on the next page? These are just a few of the sources, like highlighting the importance of sponsorship and interpersonal relationships during the 12-step process, something that we are able to incorporate into our programming. Our second, the second part would be the daily applications. So here we have our clients practice skills that are learned to promote sobriety after Lyme, things like money management, learning how to sit still, like being available, and like patience. Our clients will do this by getting groceries, going to meetings, making dinner. Everyone has to check in and check out, whenever they want to leave the house. They also have to schedule meetings with their counselors to, like practicing being available. Like that's the daily application that we really want to emphasize. Like just sitting still and telling your manager where you're going, telling your housemates what's for dinner and cooking and whatnot. This adds on to our alumni presence as we really capitalize on the relationships built in our sober living houses as they provide real world examples that are also accompanied with our professional support from house managers to clinicians to our outpatient department. This is most notable during our transitional periods, like from the step down houses to independent living, since they're able to take what they already know how to do it, and then continue to live their lives. And then our third part, our social integration. This is them resolving any legal issues, setting up doctor appointments. We have family programming, and then they move on to job training and education, or anything that will help them move forward in their careers. This is our point of difference from other facilities. We feel as though the daily application mixed with our social integration really go hand in hand to create this long-term sobriety effect. Our social theory was proposed by Durkheim. He said that a balanced routine and regulation is what makes successful societies. And what Dr. Sout was able to do was apply that to Lyman's framework as people living their lives and getting back into a regulation, a routine mixed with the social integration part, like doing dishes and working on the relationships really helps them foster that independence. This is also the framework for how we collect our data. So this is our massive workflow. I won't go through the whole thing, but basically here we were asking, how do we take our framework and apply it to qualitative meeting? This is how we did it. But here I want to emphasize our 4 sections highlighted above. So our goals, our what we accomplished with that, the action needed, and the tools. What we wanted to do was aim to accomplish. We wanted to what are we going to accomplish with our data collection? This is what we want to capture and why. This was also communicated through our whole company, which includes our outpatient clinicians, sober living house managers, and development staff. We wanted to iterate the biggest goal here was to provide qualitative findings to support the significance of our content design. And through this, we used GIPRA. I'm sure we're all aware of that, working with SAMHSA and DSAM. This mainly because it assesses the noteworthy milestones in the recovery process from mental health and physical aspects like quality of life, like sobriety, but also because it includes the social and personal aspects by asking questions regarding medical insurance, relationship quality, and employment, all things necessary in social integration and independent living. We have a few graphs that we wanted to demonstrate. This first one is our retention rates from January to June. So what we did is broke our clients down into percentages based on what time category fitted them. So you'll notice the red is for clients who stayed past 6 months. The green is clients who stayed from 90 days to 180 days. The yellow is 60 to 89 days. And then orange is 30 to 59 days. So it's about 3 months to 6 months to 9 months to 6 months plus. Ooh, 7 months. Anyways, so here this gives us data that emphasizes our alumni services, given that a lot of our clients were staying in this red category, which is over 6 months. It also tells us that it also gives us insight of our incoming clients or our clients staying past that 30-day mark. And then we can also say that our overarching goal of long-term sobriety is supported here since we have so many clients staying past 6 months. Our next graph I will hand to Mike.
Sorry, I was relearning how to unmute while sharing my screen. I was really excited to share this graph because this was a aha moment when Olivia and I were discussing this a few years ago when we first started looking at this data. And what you see here is really a longitudinal data set. It is more of an internal data set that participates in GIPRA, participates in OC or OQ. But what it really provides us is a snapshot of what's working. And you can kind of see that in the first 90 days, our people are kind of working through that early recovery piece. And as things are starting to get better throughout the first two updates. And what's really exciting for us and has impacted how we look at services is around 1 year to 15 months. You're going to see, we don't see people's lives worsening, but we see things unchanging, or apathy is how we that's our analysis, is that they're in this holding pattern. And that kind of persists. And then I go back to my old student affairs days when we used to talk about W curves in freshman year. And, there's the honeymoon period, things are getting better. And then there's initial correction, and then there's integration. And I kind of see that with our own data regarding how people move through our services. And when they come to that 2-year mark, they've made some initial adjustments. They're continued to stay connected to our services. They're integrated members in our alumni, but you also see people starting to have to meet life on life's terms. They're not in a treatment bubble, they're not in a sober living bubble, and they're doing the things that that life requires. And then you see that initial adjustment kind of take off around 24 months, right? And then what we also see is that 2 to 3 year period is where we're challenged. And what was so exciting to me is we know that when people transition from our level 3 house to our level 2 house, they're going to need extra time. And that impacts how our case managers talk, meet with the clients, and monitor that transition. And how, if they're coming out of that first that first independent, or their first living outside of alignment, treatment or housing, there's an additional challenge, right? And we know how to, we've taken this data and have been able to look at our services and look what needs to happen to improve those transitions. But strategically, and what has kind of motivated some of the expansion here, is to create multiple pathways. And the expansion that we're doing at 819 Washington is really to create the services around the legacy services from Lyman House and our sober living, and the outpatient from Triad, to create this continuum of care that can feed people's recovery on the front end and the back end. Because when we hit that 2-month period, we want to make sure that folks are still engaged and they kind of get through that next curve in life. So that has impacted how we do alumni programming. It's how we have messaged and put resources. And to me, this is like intuitively, and it gives me goosebumps whenever I look at this graph, because it's what's really happening, and it's really impacting how we can provide services and how we can be innovative in the Lyman model. Sorry, I really love that you gave me the opportunity to geek out to Olivia, so I appreciate it. Because we were practicing, and I was like, no, I really want to do this one. And she's like, fine, have it. I'm going to go to the next slide. So I want to pass this back to Olivia and kind of talk through this. And if I'm not mistaken, this was taken from a 5-year average, Olivia?
Yes, so this is a snapshot we sent to one of our partners. So our first graphic here says that 92% of our clients are receiving or are engaging in full-time or part-time or, self-employment opportunities. So what we can say here is, are the people getting jobs? Are they getting socially integrated like after their time at Lyman? The answer to that would be yes, based on this graphic. The next one, that 60% of our clients noted less symptoms in distress, like they've noted better interpersonal relationships and social functioning. What we can ask here, like, are people's lives getting better, like through Lyman? And like this is also demonstrating that it is. And then 72% by the 6-month point expressed high satisfaction in their interpersonal relationships, and which increased from the 31% at reported in intake. So what we did here was measure, everyone gets a survey at intake, and then 6 months later, we, did the same interview. What we're seeing is that, they start here and they're not feeling great about their relationships. And then after their time here, they spend time in their family programming and whatnot. We are seeing that is improving. So are people's lives getting better? Are they getting socially integrated? Are they finding jobs? Are they rebuilding their relationships and whatnot? All the aspects that are getting affected by addiction and whatnot, are those getting seen? And the answer would be yes. And then, so like, what does this all mean? So for our impact, what we can use this data for, we use it for internal service improvement. So as Mike was saying before, like with our alumni programming, we noted that people need a little more support, in those later months as they are actually transitioning out of it. So we can say like later on, we need to be paying attention to those. Let's set up like some alumni meetings, let's set up a community, just so people have a space to be together. We also use funding opportunities. So a lot of our grants and whatnot require data for the funding, but we also use it in a lot of our narratives and our applications, and it's a point of reference when engaging with partnering organizations, and we can also use it for presentations and whatnot. Then we use it for strategic planning too. So like, where should we be investing our money and time? What does the data tell us? What are we missing? What do we need to grow on? What can we do less of?
And it all kind of flows together. We want to do a good job. We want to give people a real shot at recovery. And in our hearts and minds, we can feel it and we can think it. But integrating data as a part of our culture and an organization gives us a foundation where we can be confident. And that's something that is indispensable when doing this work at Lyman. And the other piece I would say is it's compelling. And that's where I think some of the funding and the partnerships come from. We can say with confidence what our impact is. And when we want to look at ourselves and say, what do we have to do in the next 1 year, 3 year, or 5 year, we can say we need to invest in the longitude, recovery. We need a community center. And that's where some of our new services were inspired from. We had data, we had information that said this is where we can help more people. It's really exciting. And we'd love to open up for any questions, any comments. You can direct them to Olivia. She's great.
I want to thank you both. If everyone will join me in a round of applause for these two great presenters. I know that I was over here taking notes. I love the idea of the fact that the data lines up with what you're actually, experiencing, right? And it wasn't anything outside of what you already knew, right? Shout out to Josh Stout, because he actually came through CDAS. So we love to hear that. He's a great scientist, great sociologist, and we're so excited that the work that he did with you all continues to live on. I had a question, and then I'm going to go to the chat for those questions, if that's okay. One of the questions that I have is, what can you share with folks? So we've got folks here who are attending from universities, UD and outside of that, state agencies, as well as some of our community partners. Could you just give us a high level, what kind of investment does it take to start to have organizational change towards a more data-informed practice. So we know Josh Stout, he was with the university, so maybe partnering with a scientist or partnering with a researcher, but what other kind of investments did you all have to make in order to start collecting and actioning this data?
Yeah, I mean, as a chief advancement officer, I think it's time, treasure, and talent. Like when, especially with data, I think I would always encourage people to have the appetite for time, treasure, and talent. You know, Josh, Dr. Stout obviously has talent, and he gave us a time, and it was a great place for us to start thinking about this. And we had to invest a lot of time. We, as an organization, needed to learn where these academic tools could have an impact in our day-to-day operations. And, you know, I want to briefly thank DSAM for driving evidence-based practices. You know, as also having a state contract and having to do reporting, but also, you know, the improvements in reporting around SOAR. You know, it was kind of a data boot camp for us and helped us tighten up how we looked at data. So there was a big investment in time. It also takes a lot of conversations internally. I think a couple of my colleagues are joining us today, and it's talking as a leadership. You know, sometimes it was tough conversations and wrestling with a concept, but it's also communicating and helping people who don't touch data every day, but are a critical link in the data supply chain, so that Olivia can see the full picture and that executive team can see a full picture. And that took a lot of time. You know, finally, the investment. I think, you know, Olivia is has been a wonderful addition to our team. And, you know, we needed to invest in that position. You know, everybody in a small community nonprofit wears 100 hats, and you know, we're not unique in that way. But I am grateful that there was foresight to invest in a position like Olivia's, and we've been able to evolve that with how much data we've been collecting, how some of our funding sources in the past 3 years have changed, and also how our strategic plan looks and how we're working and integrating new services and what that data says. I don't know if Olivia wanted to add anything from her perspective, but I think that would be a good macro description.
I think you nailed it.
Thank you. Thank you for that. I think we have a special guest today that just joined. He heard through the airwaves. I think Josh Stout is here. If he wanted to unmute for a quick second.
Yes, I am here. I unfortunately came in at the tail end of the presentation, but yeah, heard through the airwaves that this was going on, and just wanted to quickly pop in and say hi. And it's honestly beautiful seeing that the data efforts have continued forward. That Olivia is still rocking on and doing the deal here, and you know, being able to kind of see years of work culminating into something magical here. So you know, I'm honored to hop in and can answer any questions about the initial efforts, but I'm sure Olivia has much more insight now over what's gone on over the past few years. So thank you for bringing me in.
Thank you, Dr. Stout. Our first question here from Deb Berkey is, do you have stories or quotes from participants that you can share to go with the percentages?
Absolutely. I mean, if you give me a few minutes, I have a confidentially saved quote that we've incorporated, and
Okay.
and I would love to kind of just make sure I'm saying it in this person's words, and not just so this comes from July 22. I was blessed with the opportunity to go to Lyman Recovery Wellness, and I will be forever grateful. Lyman provided me a safe space, helped me, and gave me time to examine myself thoroughly. I was able to build real friendships and a support network to get comfortable. We also get to know each other through a 12-step fellowship. I found a sponsor and went through the steps. They gave me guidance and direction when I was completely lost. They showed me what was possible. It was possible to have fun in sobriety. They put me in a position in my life to be saved. I'm still sober today. And this is the longest length of sobriety I've ever had. I no longer feel alone in this world. I have some best friends. And I get to be a son to my mother and father today. I'm part of a strong alumni community, which I'm extremely grateful for. And this comes from Matt, who actually works in the field now. And, you know, seeing Matt's growth kind of at a distance, he was able to assume a leadership position in our houses. He was an RA at a period of time. And I think now works for Brandywine Counseling in their mobile unit. And he kind of went from getting a job and being employable to doing something that's greater than what he thought he was capable of a few years ago. So, you know, we're very grateful for folks like Matt, but he is not alone. There's a woman who I know who tapered off of MAT and just recently in the past 6 months bought a house. And she's still working on integrating with her children. They're in different states. But those are the pieces that I think kind of anchor who we are and what we do. I think if you came through our sober living or if you had to hang out in our outpatient center, one of the things that's in the walls is, you know, giving people time so that they can sit with themselves and be still. It's funny, like Olivia's kind of smirking over there, but like that be still, I'm not sure if there's a clinical term, but it's something, and there's Becky, that is something for sure that I think permeates a lot of the narratives from our alumni who participate back or allow us to share parts of their story.
Thank you. That's really powerful. And I think it kind of gets to Sean Stevens' question a little bit about this idea of quantitative measures that are triangulated with qualitative data to tell this recovery story, right? And it's interesting to see, you know, the data that you put together, but then also kind of align that with the real life stories and how that shows up in people's lives. I wrote down what you said about when life, you know, when you start to have to live real life, right? Outside of these supportive places and what that means and how these, you know, we see that change in the data, right? So Dib Berkey also asked, what challenges and benefits have staff experienced integrating data collection into their work? And you mentioned some of those about the requirements for having leadership buy-in, the investment in a data analyst position and so on. But were there other challenges and benefits from having this kind of change in mindset or expansion in mindset for staff?
Yes. You know, working in a community behavioral health environment like Lyman, I think I kind of need to check my educational privilege. And that, so one benefit for me was like learning how grateful I should be with the education I've received. And, you know, that time, talent, treasure investment is you have to be patient, honest, and disciplined to make sure you bring everybody. You know, case managers didn't apply for the jobs like, you know what, I want to do Excel sheets, said no case manager ever. What case managers want to do is help people and be a loving, intrusive presence in someone's life. And educating not only like the how-to, here's the form, this is how you fill it out, but connecting the pieces and showing an integrated whole was certainly a challenge and a blessing, but it's really cool. And when you can kind of go back and say, hey, look at this. This is your success. And I think it brings a different level of confidence, optimism, and hope for the day in and day out work for the different parts of our service.
Thank you for that. That kind of leads into one or two of the other questions, in the sense of, one of the kind of pillars or strategies with Lyman House is alumni and folks who are themselves living in recovery, doing the work and so on. How have you what data have you collected to demonstrate the value of utilizing peers? So that's question one. And then question two is, have you brought clients, so maybe current clients, into that process, that data collection process? So that's kind of a one and a two around the same thing.
I want to make sure that Olivia and I heard that. The first one is how we, so I think with the peer piece, I would say that Lyman didn't know that they were doing peer support until, we were introduced to resources, but it was a part of the DNA for generations. And we're grateful for like the vocabulary, right, of peer support. I think peer support and alumni can kind of be two sides of the same coin. Because there's a shared experience in recovery, but then there's a shared experience of the program as well. And creating meaningful ways for re-engagement into service and to do something beyond yourself, I think, is feeding people's recovery. But then what our data suggested is like, we need to do stuff for alumni by alumni. And that's the new things that we've been doing over the past couple of years. Every last Thursday, we have an alumni meeting for alumni by alumni. And additionally, I'm going to throw this in the chat, we've been doing a life and recovery series that looks at something that isn't treatment, isn't 12 steps, but is adjacent to recovery. So we did a podcast type conversation with an alumni staff member and her mom about their family journey. And next Wednesday on September 25th, we're going to have Dr. Vishesh Agarwal from Christiana, who's the director of addiction medicine, our clinical director, Alicia Emanuel, and Casey, who's an alumni, but also works at DSAM, I think as peer outreach, kind of providing a little bit of science, a little bit of provider, a little bit of expertise around what providers see, and then a lived experience of that. And those are some of the ways that I think we try to incorporate peers and alumni. And I'm going to ask you to repeat that second part of the question, just so either Olivia and I could answer that effectively.
Yeah, for sure. The question was, have you brought clients into the data process? Do they help with data collection, or is more of sounds like a lot of the data is based in GIPRA and possibly administrative data, but are you bringing clients in to help with the process of data?
So I would say qualitatively and very informally, we'll pose open-ended questions to engaged alumni to ask them, like, what does recovery mean to you? Or what do you think of this? And maybe in a couple of years, there'll be a cute Qualtrics outcome. But right now, it is really grassroots, and what that looks like is, what do you think of this program? Is this something that would feed your recovery? And who needs to come to this? Who can you invite in your group to come to this event? So it's kind of engaging not our services, but our community program, and asking them to look at their own social networks as well.
And just to add to that, with the GIPRA, a lot of it's like during our intake. So while we're getting questions about like maybe insurance and whatnot, we can go ahead and ask that. So it's all a part of our onboarding process, which makes it a little easier for our clients. But also, like, if we want to extend our research to interviews for our alumni, what I notice is that a lot of them like are willing to come back and tell their story, because like how much Lyman like does for them and whatnot. Like the buy-in was not very hard at all. But we also do offer like $25 cards to Wawa and whatnot. for their time.
Yeah, you don't have to sell us on Get Pro over here. We know how it goes. And can be kind of intense, right? So there's a question about do you have a policy on firearms for your residents? But maybe that could be an offline question, or you could share your contact information and we could you all could talk directly about that. I think Deb Berkey wants to go deeper on this idea of using folks using clients in the data collection process, leveraging the work of PAR work, so participatory action research, right? And that includes things like design, instrument design, actually being the ones to conduct interviews, looking at the data itself, right? So you shared that really powerful slide, Mr. Webster, and have you shared that back with, you talked about sharing it back with staff, but have you shared it back with alumni, clients, to say, hey, this is kind of what we expect to happen? You talked about that plateau. Have you talked about that with them and involved that in that process, if I'm understanding Dr. Berkey's question? The answer could be no, and that's okay.
I'm so bad at Zoom now. I apologize. So working what I've used that data for is probably not very formal, but we've one of our first steps was to formalize a alumni association, for lack of a better term, and having a core group of engaged alumni who are stable in life, stable in recovery, to help kind of be town criers and community pillars for some of the programming and outreach that we're doing. And one of the challenges and where the data came in to help people see what we're trying to do here with alumni is like, there's this, I have to give back to Lyman sense, right? And as a person who works at Lyman, I want to make sure that the people currently in our services, but the people who've been touched by our services are being like their recovery is being fed. And while service is a big part of a lot of people's recovery journey and program, convincing these leaders in our alumni community, like, no, this is for you. You don't have to go into level 3. This is for you. This is a place for you. This is your sandbox. And using that data between the second and third year that we were kind of talking through a few minutes ago, that's the data I use to kind of say, like, that's where people kind of fall off. And what does that look like? Boyfriends, girlfriends, integration with kids. My first job in recovery isn't going to be my forever job in recovery. Having a more sustainable living situation. Those are the types of challenges that aren't the right fit for level 3 or level 2 folks, but it's something, creating a sandbox for our alumni to speak from their own experience, to have that conversation, and for us to bring in either people who have been there 5 years ago or other resources to inform that. It has been helpful. One of like the private public partnerships that was kind of effective is Nestor, which is a fintech real estate company based out of Wilmington. They help homeowners say, how much should it cost to maintain your home? Like, you buy this house and you're like, oh my God, the hot water heater went. And they kind of do, like, it's almost like a cost of operations report for homeowners. They provide that service to all of our alumni for free who want to sign up. So that kind of came out of some of the conversations. It's not being utilized. It's not like hundreds of our alumni are engaging in it, but that was something that did come out in the past 12 months. But the challenge was really like, we want to do this for you, and this is why. And that's where we use the data.
Thank you. I want to open it up for maybe one more question. If folks have a question for either Mr. Webster or Olivia or Dr. Stout on this, and if you all want to connect with them, is it okay to put your email address in the chat, and they could, if they have more questions or are looking for different connections or alignment?
Absolutely. I could talk to the wall, so just, feel free to contact that. Yeah. And if Olivia doesn't want to talk to you, she'll send them my way.
That's a good policy, Olivia. Good policy. Any other questions? Any folks have questions for our great presenters and our visiting scientists? Sharon, did you have anything?
No, I just want to really thank both of the presenters for bringing such a wonderful example of not only giving us an overview of the work that they're doing, but just showing us, the importance of using that data to continue to improve programming. A lot of times we focus on more needs assessment, things of that nature, but this was just a remarkable example, in my opinion, as a member of a team that's done a lot of program evaluation. This is what we really, really like to see. That the data is meaningful and that there's a recognition that the data can change over time and that this is just a continuous loop. And it's very exciting to me. That's all I can say. So thank you on behalf of the whole team, and thank you for bringing it to life. It's really been a very impressive experience. Thank you so much.
Thank you.
And please put the information that you shared or the events that you have coming up, please put those in the chat. If you also want to send them to me, I can make sure they get out to the folks that participated today. So if there's flyers or Evite or whatever, I'm happy to get those out to people so we can get more support and attendance and awareness around these issues. I think now we've kind of reached the portion of our program here for folks. Any other folks want to share events that are coming up? There may be some cross-pollination of groups here in Wilmington, Delaware, whatever, here in the state. The offer stands for everyone if you want to share flyers with me, but you can send them to me. I'll put my email in the chat and can connect with you that way. Thank you so much for adding that to the chat. Sharon, is there anything you want to add?
I think Dan has his hand up.
I can't see Dan, but yes. O'Connell.
I get that can't see quite a lot. Oh, now I froze. Really? Oh, there we go. Real quick, I don't know if people got the email, but the documentary, Silence on the Streets, is playing on Main Street in Newark tonight at 6 p.m. at the Main Street Movies. I believe it is free to attend. I'll put the link in the chat here real quick. But if you or anybody you know isn't doing anything, there's a wonderful documentary on addiction on the streets that it was screened at UD here not long ago, and is rolling out. And so tonight they're going to screen it down on a big screen on Main Street. So grab some popcorn and head on down. I will throw the link to that in the chat here real quick. Yeah, MJ, when you said, is there anything? I was just like, oh wow, maybe this thing.
Yeah, no, that's a great point, Dan. And I've actually seen it when it's been at the library. It's very good. I encourage people to check it out if they have some time this evening. It's a powerful thing to watch. And when I went to it at the library, there was post discussion, but that's cool too. Anyone else? Ms. Cornish, anything happening at BCCS you want to share?
Thanks, MJ. Not at this time, but I do want to thank the Lyman House for all that they do for those in recovery. Mike is a part of our team now, a part of our outreach team that I oversee. He's doing an exceptionally well job. So I thank them for the foundation that they've offered and provided for him. I don't have anything to share. We're just out. We're going to be out in October, and as well as this month, I think we're supporting the overdose awareness event on Saturday. And then Prevention Month is October for us, so we're in planning stages to do a couple of events. And as soon as I get the flyers approved, I'll get them over to you, MJ.
Thank you, ma'am. That also reminded me that the cause is now having a monthly purpose, which is a place where folks in the prevention space and folks in recovery can come together and once a month and have this discourse and fellowship and all of that. So if I get that flyer from Scott Michaels, I will send it out when we send out the materials after this meeting. It looks like Bill Lynch has a comment about naloxone data, but he left, so.
I'm here. No, I'm still here. Can you hear me?
I was gonna say, I don't see you anymore. Yes, sir.
So this is actually pretty game-changing information. This is actually pretty exciting news. So there was actually a study that was done out in California, the San Francisco area, the San Francisco County and 2 surrounding counties, looking at the use of naloxone in out-of-hospital cardiac arrests. And those were individuals who presented with a cardiac arrhythmia that was either asystole, a total flatline, or what's called PEA, which is pulseless electrical activity, which is the worst 2 cardiac arrhythmias you can get to be as dead as you can be. And what they found is that individuals who were opiate-related cardiac arrests out of the hospital, but those who were not opiate-related cardiac arrests, that the number needed to treat of those 2 groups to show benefit, where benefit was defined as return of spontaneous circulation, which means that they had their pulse come back and they had blood flowing through their system for 20 minutes or longer to count as a return of spontaneous circulation. And when you look at these clinical trials, they have a number that's called the number needed to treat. So the question was, how many people would you have to give naloxone to who were out of hospital cardiac arrest and have them respond with the return of spontaneous circulation for 20 minutes? And that was 1 out of every 9 people. They're unbelievable numbers. And then they also followed them to time of discharge. So when they got to the hospital and they were actually discharged from the hospital and survived the absolute total cardiac arrest. And that number was 1 out of every 26. So that someone who, if there were 100 people that had a heart attack and actually had asystole or PEA, and they were dead as could be, 4 of them walk out of the hospital and survived, and literally 1 out of every 9 would have a return of their heart functioning correctly. The reason this is important is because of a different spin on the data, and that is the ability to use this information to destigmatize naloxone. People now wouldn't have naloxone in their home to reverse somebody with opiates disorder and opiate issue, and it's great for that, and it should be in the whole bit. But we all know there's a pushback because that's who this is used for. This study shows that this may be beneficial just to someone who in your neighborhood, your home, who's living with you, whatever, who has a cardiac history and has the potential, if they don't have a cardiac history, to have a sudden heart attack that causes total asystole or PEA, and that you could potentially give them naloxone to reverse this cardiac event by having them return to spontaneous circulation and give you potentially 20 minutes for EMS to arrive there and have your family member, relative, or someone survive from a cardiac perspective. This is a bell ringer that everyone should have naloxone in their home and in their car and with them all the time, because you could potentially have benefit in a cardiac patient, irrespective of opiates are involved or not. It's unbelievable data. They're going to do a potentially much larger trial, but it really is a game changer with regards to the benefit of naloxone in cardiac patients that now will be beneficial in cardiac patients, irrespective of opiates were involved in their cardiac arrest or not. Pretty fascinating stuff.
Thank you for sharing that. If you have the study or if you have a link for us, please let us know and we'll make sure everybody has access to that.
Absolutely.
Thank you so much. Deb Berkey.
Thanks, MJ.
Yes,
I just want to
ma'am.
call attention to 2 recent dissertations that were published. One is Amy Herb's, which is looking at peer recovery, and the other is Jake Andrews, which is looking at Delaware law enforcement perceptions of drug diversion and harm reduction programs. If you're interested in either one of those, I can drop my email in the chat for those of you not affiliated with academic institutions. I'm happy to send you a copy or connect you with the actual authors themselves. They would both be excellent resources. So I just wanted to give a shout out to two of our recent graduates.
Thank you, ma'am. Anyone else? Anything else? Resources, events coming up. There's opioid stuff in JAMA, that is correct. Yep. Thank you, O'Connell. Thank you so much. Anyone else? Well, this has been a really robust conversation, and I'm so glad that the information and the data is getting out. Sharon, do you want to close us out?
Sure. I would just like to mention that not only is it Recovery Month, but it's also National Suicide Prevention and Awareness Month. And I always like to emphasize, as we all know in this Zoom space, that mental health and substance use are things that do not occur in vacuums. They sometimes cross over. And it's just important to recognize those associations. So when we're thinking about observances this month, we can think about that as well. But I just want to thank everyone for coming today. We know how busy you are. We know how dedicated you are to your individual missions, but also we appreciate very much the support of using data, you know, in such an important way to affect the lives of people. We saw it today. We heard it today in the way that Lyman House is using their their data to improve their programming and directly improving the lives of the folks that come to them for services. So it's very exciting to hear that. We look forward to the publishing of the 2024 Epi Report, which should be out soon. As you know, it's a series of modules on a variety of topics that address various aspects of behavioral health, but as well some populations that experience disproportionate risk. And in addition to the data, we also have a number of products that are associated with that, including a series of infographics that you would all be free to download and distribute at your various meetings electronically or in paper. We produce some slides that you'll be able to use for your presentations so that you can continue the work of, promoting the data in your various communities. And at some point, we'll probably make a presentation about the data and talk about some of the highlights that we've discovered this year. So we're very excited about that. And then we will meet again, MJ, in
February 2025.
February 2025. We meet, as you know, twice a year. And we look forward to our next meeting, but we don't go away in between. So if you have questions about the data, if you have ideas for data products, if you want to connect with us in any way, please reach out. And do be aware that, as Shauna described earlier, that we do have a regular e-news blast that comes out. It comes out once or twice a month, depending on the month. And we try to push out resources and new information to you in a more timely manner that way. So lots happening. We're grateful for all of your participation, and we hope you have a really wonderful rest of the day and a good 6 months if we don't see you before the next meeting. That's
Sharon,
it.
I got a real quick interjection. So for those of you who aren't familiar with the 2024 Higher Education Suicide Prevention Conference is in person. I will drop the Eventbrite in the chat. It's the morning of October 4th here at UD. So if you get a chance to attend that, that would be great. I'm going to put that link in the chat as well. We'll send all of these links out to you post meeting, so you don't have to try to grab them now, but if you want to, you certainly can. That is the Higher Education Suicide Prevention Conference. We've attended years in the past, presented years in the past, and it's always a really great conversation. Usually they have breakfast and a good keynote and self-care activity. So if you get a chance and you have that time, October 4th in the morning, please do. Thank you so much, everyone. I appreciate you, and have a great rest of your day.
Thanks.
Thank you.
Thank you, MJ.
Thank you so much.
I had a lot of fun, and I